Okay, I want to say good morning or good evening, depending on where you are logging into this event. I'm Carolyn Westhoff. I know people will be logging in and out a little bit as the meeting goes on. And what's important in that respect is this event is going to be recorded and available on the web as an enduring educational material. Today is the second of what will be 6 sessions. Our first session on patient-centered care and the demography of IUD use is available at the symposium website and will remain there for those of you who missed that. Today we're going to be talking about current IUD technology and performance, and we're also going to talk about adverse events. This is probably the most clinical of all 6 sessions. And while today emphasizes current technology and our current knowledge, our very last session on June 23rd is going to look at the future and IUDs under development and research that's going on. Next slide. The faculty today are all wonderful colleagues of mine with great expertise in the areas of today's talk. They will be presenting in the order that you see them listed here. Next slide. And here's our agenda. We're going to start with considering current IUD technology with Bimla Schwartz, and we will take Q&A immediately following Bimla's talk. We will then have a series of discussions making one panel on adverse events. You can see the topics in the speakers, and we will have a combined Q&A at the end of the panel for all of those topics. But if people want to place questions in the chat at any time during the presentations, please go ahead. We will, answer them if we can, and we will return to them at the end during our discussion. Next. We have the learning objectives listed here because this is an accredited session for CME, and so this is here and you can read it in more detail on your own time. Next. And we have an accreditation statement. There is going to be a course evaluation. You will receive that by email after the session today is completed, and then you can fill out the course evaluation. You'll get your CME credit. Next. And all of the faculty have provided their disclosures here. And next slide. And again, you will be able to, review those in more detail if you wish to on the website. The first slide of disclosures was today's speakers, and the second page are all the members of the coordinating committee who have been organizing this entire symposium. Next. And I very much want to acknowledge that we have received support from Bayer, Cooper Surgical, and the William and Flora Hewlett Foundation, without which we could not put together this these sessions. So we're very grateful to them, as well as for future IUDs, the Mona Lisa and Sabella companies, who also provided gifts to help support the symposia. And I also want to acknowledge Rachel Farrat, who many of you have been communicating with by email, who is the logistics wizard pulling all of this together. Next slide. So our first talk will come from Bimla Schwartz on IUD technology at present. Welcome, Bimla.
Thank you, and it's great to get to see all of you bright and early in the morning here in California. As we've noted, I have no relationships with any of the makers of any of the devices I will be talking about today. Next slide. So the story of intrauterine contraceptives is one that goes back many, many generations and is attributed to the genius that allowed transit across the deserts with camels. And it was noted that it's actually rather inconvenient to have a pregnant camel on your caravan when you're trying to move large volumes of materials across an inhospitable environment. And what we have here on The screen is a picture of one of those early IUDs, which was discovered as something that if you put a small stone, this one is estimated to be just 25 millimeters in diameter, into the uterus of a camel, it created some version of sterile inflammation that allowed that beautiful camel to get herself all the way across the desert with the caravan as intended. Over the years, starting in the early 1900s, there were many variations, next slide please, of IUDs that were developed. And you can see here from one of the IUD collections in the museums just how many variations on the theme were tested at various times. Each of these was somebody's great insight of ways to try to make things a little bit better, either for the women involved or their families or the clinicians, starting from early devices with silkworm and silver and copper, and then the Lippy's was just plain plastic. Next slide, please. And many of these early ones were made out of plastic, and that added some advantages in that they were more flexible. One of these IUDs, we need to be very clear, the slides seem to be advancing on their own, which might be better if we could slow down a little bit because I am not keeping up. Thank you. And if we want to just take a small break, sometimes what happens on these slide decks is that there is an auto advance setting that has like rehearsed timings checked. I'm not sure if that's what's going on for us, but we can just give it a try here and see how it goes. As I was saying, the Dalcon shield, the one that is circled here, looked actually quite different than most of those other plastic shields, and it looked very, very different than our current medicated IUDs, which are shown on the right. And which are going to be the focus of what we're talking about today. And the main point is that the Dalcon shield was a very problematic device. It gave a bad name to all of this technology. And there's lots of reasons to think that it was really not like the ones we currently have on the market. Next slide. So the first medication that was added to these intrauterine contraceptives was copper. And that really was a quantum leap forward. Copper interferes with sperm transport. It inhibits the sperm's ability for capacitation, what allows it to fertilize an egg. And when they've done these clever studies where they've looked at whether sperm are able to get past intrauterine contraceptives into the fallopian tubes of women who have an IUD in place, they found that it's very rare for there to be any viable sperm in the fallopian tubes of an IUD user when that's a copper IUD. In addition, copper has some like added bonus benefits that I think are probably worth having us think a little bit more about when we think about all the challenges that face people around the world. And that is that copper also has antiviral properties, both against HIV, against HSV2, as well as against the human papillomavirus, which causes cervical cancer. Next slide. With lots of hard work by many of our thoughtful colleagues, the copper-containing IUDs evolved from the early copper T200 to the 220 to the 380 to now what is the standard of care, which is the T3080A. You can see that those numbers went up, and that is the number that reflects the surface area of all the copper that has been wound around that flexible core that holds up the copper. The A in the T380A is because there is some silver in the core of the T380A, and that was found to prevent fragmentation of the copper and allow the lifespan of the total IUD to last longer and perform longer than the earlier IUDs. So this on the right is the one we're going to mostly be focusing on when we talk about our copper IUDs. I recognize that there are many products around the world that are variations on this theme made by different manufacturers. Next slide. But I've often also wondered what our world would look like if Apple, which has done such a great job of moving the iPod and the iPhone and an iPad and a whole bunch of other devices into common use, had taken on the challenge of moving IUDs. Because the Paragard, back please. So the Paragard was introduced in the US the same year that Apple released that cutting edge Macintosh 2. And it remains really a workhorse for us in the land of copper IUDs. You'll note that it was FDA approved in 1984, and it actually took 4 whole years to become available in the US. And then on after that, Mirena, the first of the hormonal IUDs, was introduced in Finland in 1990. And it took a full 10 years for that to come to the US. That was 2000 was right when the first iPod was introduced. And in many ways, this 52 milligram IUD remains the standard bearer. So we haven't done a lot beyond where we were back in the Mac and first iPod generation. Next slide. But there have been some refinements, and we're going to talk about those today as we think about what it is that makes these devices that are now available to us a little bit different. This figure is from Kylina, which shows that the dimensions of Kylina are slightly bigger than some of the Apple EarPods, but still smaller than our trusty paper clips. Next slide, please. So this figure shows the timeline of those quantum leaps in hormonal IUDs. 20 years ago, Mirena came to market, at least in the US, 30 years ago in Scandinavia. In 2013, Skyla, which is marketed in Asia as JDES, was introduced. In 2015, Liletta, or what is marketed in the UK as Levocert, was introduced, and that is really the generic version of Mirena, which was a quantum leap in bringing the price down, which is really important in increasing access. But in terms of the actual medicated IUD, wasn't really any different. And then in September 2016, Kylina was introduced. Next slide, please. So all of these IUDs contain levonorgestrel. This is that variation of progestin, the hormone the woman's body produces when she's pregnant, that I think of as basically faking out the body by making it think that it's pregnant already and kicking into effect all the mechanisms that female bodies evolved with so that pregnancies don't get started once a pregnancy is already in the uterus. Levonorgestrel modifies the cervical mucus in ways that make it hard for sperm to penetrate that mucus and get to the upper reproductive tract. It changes the uterine immune microenvironment, and it thins out the endometrium in ways that make it hard for implantation to occur, which all the assisted fertility specialists would want us to know is when you actually become pregnant, when a pregnancy is actually able to implant in the uterus. There is some systemic absorption of these hormones, which we'll talk about in a little more detail. And in some cases, ovulation is suppressed, but it's definitely not consistent. Next slide. So what are the actual medications contained in these medicated IUDs? In the copper IUD, we said that was 380 millimeters squared of copper. In Mirena and Liletta and Levocert, which for these purposes I will now combine under the heading of our 52 milligram levonorgestrel IUD. And then we have those lower dose ones that contain either 13.5, again marketed as Skyla, and 19.5 milligrams marketed as Kylina. Next. When we look at what the levonorgestrel release into a woman's body on a daily basis in that first year of use, understanding that like any pharmacological curve, there is drop off over time, but in that first year, of course, the copper IUD is releasing 0 levonorgestrel into the woman's system. The ones that had a reservoir containing 52 milligrams release approximately 20 micrograms per day, while the lower dose ones are releasing either 8 or 12. So considerably less in that first year of use. Next slide. When we look not just at the first year, but over the first 3 years of use, what the exposure is, the highest dose hormonal IUDs are releasing a 218 nanograms per liter, while the lowest hormonal IUD that's commercially marketed is releasing 74.3 nanograms per liter. And Kyleena is 114 nanograms per liter. So some variation. And if you're looking at the average dosing there, you'll think to yourself, wow, that's sort of interesting. It looks like Kyleena compared to our Liletta is maybe almost just half the dose. And yet Kyleena says it's got about 5 years of juice in it. Next slide, please. So when we look at whether that's enough hormone to change the bleeding pattern, which was one of the concerns that people had with the copper IUDs, we see that amenorrhea, meaning no bleeding at all with the 52 milligram levonorgestrel IUDs, occurs for about 20% of women, about 1 in 5, someplace between 15 and 24%, if you want to be precise across the studies. So that is the most amenorrhea that you can get with one of those hormonal IUDs. Those that have lower doses of amenorrhea. So the 19.5, only about 13% amenorrhea at 1 year. And for the lowest dose, only 6% at 1 year. At 2 years, as you would expect, those numbers go down a bit. Though for the 52 milligram levonorgestrel IUD, really quite similar. And about 1 of every 5 women is amenorrheic at 2 years. With the lower dose, also about 1 out of 5. With the lowest dose, it's only about 10%. And with the copper IUD, just because there is no hormonal effects there, it's going to be even lower, and we're not expecting any changes in the woman's bleeding cycles due to the placement of the IUD. Next slide. So sometimes it can be confusing to patients that they are not having their menstrual bleeds, but they may still have ovulatory cycles. And so that's an important thing to distinguish for people who are looking for non-contraceptive benefits like acne reduction or changes in the effects on their mood of their menstrual cycles. When we look at how many women are having ovulatory cycles at 1 year, with the 52 milligram levonorgestrel IUD, 45% of women, so almost half of them, are ovulating. At 4 years, that goes up to 3/4 of women, so 75%. With the lower dose IUDs that contain the hormone levonorgestrel, almost all women are ovulatory in all cycles. And of course, with the copper IUD, it is 100% of those cycles. Next slide. When we look at how long these reservoirs are thought to last, they are labeled per the US FDA for the copper IUD for 10 years of use. The 52 milligram levonorgestrel IUDs have recently updated their labeling, say they're now good for 6 years, which makes sense since the 19.5 milligram says it's good for 5 years, and those who can do some version of extrapolation would think that if you can get 5 years out of 19.5, you probably can get at least 6 years out of 52 milligrams. The 13.5 milligram levonorgestrel IUD is only approved for 3 years of use. Next slide. When we look at studies that have tried to follow women out longer while using these devices, there is good data for extended use for the copper IUDs out for 12 to even 20 years. I tend to think of this the same way I think about the copper piping we put in some of our homes when we're installing plumbing, or the copper cookware we use in our kitchen. It doesn't usually go very far, and it tends to do the job we want it to do for many, many years. So I think of this as a nice alternative to long-term contraception for women who like the profile that the copper T388 provides. In terms of extended use of the 52 milligram levonorgestrel device, there's good data out to 7 years, and there's data in progress that I think may allow us to see that for even more than 7 years in the not too distant future. Again, just extrapolating if you can get 5 years out of 19.5 milligrams. No data on extended use of the lower dose products. Next slide. Coming back to just the dimensions of these different IUDs and whether that makes any difference in the way we think about the products that are available to us, they are all smaller than a paperclip. Next slide. And when we look at the size of the frame for the Paragard or the copper T380A, that one measures 32 millimeters horizontally, meaning across the arms, while it is 36 millimeters tall. The Mirena is similar in the arm span of 32 and the height of 32. Liletta and Levocert match that exactly, 32 by 32, while the lower dose hormonal IUDs, Kylena and Skyla, have slightly smaller arm span, but really it's a difference of 2 millimeters, 28 instead of the 32, and somewhat shorter stems, so 30 millimeters instead of 36. In my own clinical experience, I would say this is rarely a clinically significant difference. Next slide. The placement tube diameter, you might think would also be a place where these products would differ. Again, the differences are a matter of millimeters, and in my own experience, I would say not a clinically relevant difference. Paragard placement tube is 4.01 millimeters. Mirena is 4.40, a little bit bigger. Liletta Levocert is the biggest at 4.80. And Kylena and Skyla are tied at the smallest at 3.80. But again, not anything that means you couldn't place any of these devices for a woman who hadn't previously given birth if this was her hormonal contraceptive or intrauterine contraceptive of choice. Next slide. Another difference between these devices when we're looking at how we can style them has to do with the colors and the additional detailing. And so you can see here that they have different colored threads. Paragard has white threads, Mirena has brown threads, Liletta and Levocert and Kylena all have blue threads, Skyla has brown threads. Paragard is very easily seen on ultrasound. The hormonal IUDs a little bit harder to see on ultrasound. So Kylena and Skyla, the two newer hormonal IUDs, have added a ring on the T, which aids in the identification of these devices by ultrasound. All of these are very easily picked up with X-rays and can be safely imaged using MRI if you have questions about where the IUD has landed. Next slide. So perhaps the biggest question for many women is how well does it work? And what we have on this slide is data on efficacy as measured with the Pearl Index, which is the number of estimated pregnancies seen per 100 woman years of observation. Our colleague James Trussell would want us to think carefully about the ways in which that estimate may change based on the study design that was used. Clearly, if someone is going to experience a failure, it's going to happen earlier. And if you have a study that only follows women for a short period of time, it may seem like these numbers are higher. If you have a study that includes more young women who are more likely to be fertile, again, that number may seem like it's higher than it would be otherwise. But what I have here in this table for you is pooled estimates across a number of studies. We published this in our chapter in contraceptive technology. And you can see that in the first year of use, the Pearl Index for the copper T380A is 0.7, while that for the 52 milligram levonorgestrel IUD is considerably lower at 0.19. For the lower dose levonorgestrel IUDs, the first year Pearl Index is within the same 95% confidence interval, so not significantly different than the 52 milligram levonorgestrel IUD, but maybe a whiff that the 13.5 milligram levonorgestrel IUD would be less effective, as the point estimate is 0.48 compared to that 0.19. So again, the 95% confidence interval does include that 0.19. When we look over the lifetime of the product, which again, as a reminder, is 10 years officially for the copper T380A, for the 52 milligram levonorgestrel was 5 years when these studies were initially done. For the 19.5, again, 5 years. For the 13.5, 3 years. We'll see that the lifetime Pearl Index changes. This may be a little bit paradoxical. You'd think, oh, you're following people for more time. Wouldn't we see more pregnancies? But actually, we tend to see less pregnancies with time. People who have a failure tend to have a failure early and then switch out to another method. And over extended time, we have bigger denominators. So the lifetime Pearl Index of the copper T380A is a little bit lower at 0.52 pregnancies per 100 woman years of observation, but that is still probably about 10 times higher than what we see with the 52 milligram levonorgestrel IUD, where it is estimated at 0.06 pregnancies per 100 woman years of observation, which I keep in my head as the easy to quote 1 in 1,000 chance of getting pregnant. Over the lifetime of the product, the lower dose hormonal IUDs are considerably less effective. So a Pearl Index there of 0.29 for the 19.5 milligram levonorgestrel IUD and 0.9 for the 13.5 milligram levonorgestrel IUD. When we put that in the larger context of contraceptive options and we think about what the Pearl Index is of most of our oral contraceptives, those range from 0.29, so on par with that 19.5 milligram levonorgestrel IUD, all the way up to 2.86. So most of these IUDs, even at the lower dose hormonal version and with the copper, are more effective typically over extended use than the first year of an oral contraceptive. Next slide. So lots to think about with the available copper IUDs. However, when picking a device for a patient, rarely is the focus on the thread color or on anything about the exact diameter of the placement tube, which doesn't seem to have much clinical difference. Rather, I would say issues around cost end up making a big difference in a lot of settings, and whether or not there actually been clinicians who've been trained to place these IUDs and make these options available to women in their community. So I'd like to turn it over to Dr. Heinemann to help us with any additional discussions about how to help think about these. And over the next little bit, we will be focusing on issues related to pain and bleeding and infection and that 1 in 1,000 risk of uterine perforation. But I'm happy to try to answer any questions that folks might have at this point, and see if any of those are coming in through the chat. And in the meantime, maybe just take the opportunity to say one of the other issues that I think is very important clinically is whether or not women feel like they need to cede their autonomy in order to use an intrauterine device. And I do feel it's really important for us to let women know that they can safely remove their own IUD by tugging gently on the threads at any point they would like to have that IUD removed.
Thank you, Bimla, very much. I agree. We covered the self-removal a bit in the previous session, and in the very early session we did in May on the day that the in-person program was supposed to happen. I just want from the chat, I have two clarifications that I just want to give to the audience. One is there was a much earlier hormonal IUD that many of you were too young to have ever known about, called Progesta-Cert, that was available in the US and I think available in other countries as well, from 1974 to 1986. So it disappeared before today's copper Ts were finally approved. And I think the main reason it disappeared is it was a device approved for only 12 months and probably usable up to 18 months, but that really would be no contest compared to today's longer acting ones. And one other minor clarification about the silver in the T380A, that silver is a core on the copper wire itself. It's not like in the plastic of the IUD frame. It's there in order to stabilize the copper itself, so the copper doesn't dissolve so quickly. And those are the only clarifications from questions that came up in the chat, but I see there are a few other chat points right now.
There's some question on the difference in cost, at least in the US, the difference between the generic and the brand name 52 milligram levonorgestrel IUD is about $50 versus $850 or $900.
And of course, the costs vary around the world in terms of whether things are in the private sector or in the public sector. So there's a lot of variation there. But saying that, I agree with what the point Bimla just made. Okay, moving on to Klaus, please.
Can you hear me? Hello?
Yes,
Can hear
okay,
you.
perfect.
we can hear you.
I wasn't sure if I was still on mute. It didn't show here. Yeah, hello. My name is Klaus Heinemann. I'm the principal investigator for the EURAS IUD study, my favorite study. So many thanks for the opportunity to present the results here again. Next slide, please. The study was a post-authorization safety study, which was requested by the European Medicine Agency 15 years ago to investigate the perforation risk for LNG IUDs, basically for Mirena. There was no other IUD, LNG IUD back in the days. The study was supported by Bayer Pharma, so the MAH, is an unrestricted grant and was supervised by an independent safety monitoring and advisory council. Next slide, please. In 2006, Mirena had been on the market for a while already, but it was still unknown what the perforation rate actually is for this new IUD, and also if there's any risk difference between Mirena insertions and copper IUDs regarding perforation. Next slide, please. So we were asked to conduct a prospective non-interventional safety study. It was a large cohort study, 2 cohorts, Mirena and all other copper IUDs on the market in Europe. So we had dozens of different shapes and copper loads included. And the initial study was planned for 60,000 patients, which were to be followed up for 1 year, basically. And during the study conduct, we decided it would make more sense to also have 5 years results, because Mirena was supposed to stay in the body for 5 years. So the first almost 40,000 women recruited into the study were then also followed up after 5 years again. So the study ran from 2006 to 2015. Next slide, please. We conducted the study in Finland, Sweden, UK, Germany, Poland, and Austria. Next slide. And as with all our EURAS and INAS type studies, our main aim really is to collect as much information at baseline about potential risk factors of the patients. So things you wouldn't usually find in claims data or other secondary data sources. So here we really looked not only into previous use of IUDs and other hormonal contraceptives and past medical history, but we also were interested in the breastfeeding status of women when they had their last baby, so last conception, or no, the last delivery basically. We looked into family history of different disease entities like breast cancer, VTE, ATE. We differentiated between new starters, so women who have never had an IUD before, and those who were on consecutive use or restarters. All patients were followed up, and the doctors as well, after 1 year and then after 5 years again, in this part of the study I'm presenting today. And all SAEs reported by either the doctor or the patients were documented. And those relevant for our study outcomes, for instance, perforations, but also pregnancies and other outcomes, were validated with the treating physician. I come to this a little later. Next slide, please. So basically, all women who received a new IUD, so a newly inserted IUD, were eligible for the study. They had to be above 18 years and had to sign a consent form and data privacy form. And there was no advantage or disadvantage for the physician who prescribed the IUD off-label. So we are also interested in those women who received the IUD for other reasons than contraception. And all women who were recruited until August 2010 received an additional 5 years follow-up. That was approximately 40,000 women out of the 60,000 women included. Next slide, please. This basically shows our recruitment process. So we recruited physician or HCP networks in the different countries who served as not as investigators, but rather recruiting physicians or midwives. They asked patients prior to the insertion whether or not they would be interested in participating in the study. If so, we had different questionnaires, baseline questionnaires, for both physician and patients, depending on breastfeeding status and the success of the insertion. Because some of these insertions were already unsuccessful at insertion level, there was already at the insertion perforation set, so these women never received the IUD basically, but they were still counted as a perforation in our study. Next slide, please. As I said, approximately 40,000 women or 39,000 women ended up in our 5-year study. Out of those, 30,000 received actually a 5 years follow-up questionnaire. The remainder, so approximately 9,000, didn't receive the 5 years follow-up because they had either no IUD in place after 1 year anymore, so it was already removed, or they already had a perforation, or we never received any information from the woman back after 1 year, so only the physician answered follow-up questionnaire, but the woman didn't, or the woman already dropped out of the study. Next slide. So the study objectives, as said before, we were looking into the evaluation of uterine perforations during and after insertion of IUDs, and we were supposed to compare perforation risk of Mirena and copper IUDs. Next slide. This slide is showing the numbers of participants in our study. So as you can see, the majority of participants came from Germany and United Kingdom, where IUDs are actually quite popular. As you can see, for instance, in Poland, they are much less popular. So we had only very tiny numbers, a couple of 100 patients from Poland. And Finland also contributed lower numbers, but the reason was really that they only have 4 million inhabitants, I think, in total in Finland. Next slide, please. The response rates were actually astonishing good after, or well, after 5 years. So we saw approximately 80% of women responding after 4 years of not hearing from us. So they received a 1 year follow-up and then another one after 5 years. And still 80% of those who received the 5 years follow-up answered us. It differed a little bit between countries. So we saw 90% in Austria, but only, let's say, 65% in Finland. But overall, we didn't expect these high response rates actually. Next slide. The main difference between cohorts, as to be expected, was really age. So we saw much higher proportion of women above 40 in the Mirena group compared to copper IUDs. As you can see here, this is the age distribution, light green, showing in the age group of 40 to 49, almost twice the proportion of copper IUDs in dark green. And this, on the next slide, please, resulted also in differences between deliveries in the past 12 months before insertion. We had a lower number in LNG IUDs compared to copper IUDs, and also in the lower number or lower proportion of women who were breastfeeding at the time of insertion. So that differed between 9.6 and 14.9%. Other baseline characteristics, including BMI, educational level, and also medical history, were quite comparable, except for some disease entities like endometriosis and fibroids, which were more frequent in Mirena users. Next slide, please. The validation process worked in a way that if we received any adverse events of interest for us, so perforation, cancer, VTE, or pregnancies, unintended pregnancies from the patient, we contacted the patient to gather additional information and then also contacted the treating physician, not necessarily the recruiting physician, but really the physician or hospital who actually diagnosed and or treated the event to get additional information, so really source data. And only after this medical validation process, we classified the events as either confirmed, ending up in our analysis, or not confirmed. Next slide, please. In total, we saw 59 perforations in Mirena users in this 5-year study or sub-study, and 18 perforations in copper IUD users. And as you can see on the slide, the majority of perforations was diagnosed at 1 year follow-up. So it was really either driven by symptoms or by routine examinations already discovered very early, but also a substantial number was diagnosed only after 5 years, sometimes even only at removal. I show these data later. Next slide. Incidents were higher in the Mirena cohort. So we had incidents of 2.1 in 1,000 insertions for Mirena and only 1.6 in copper IUD users. Next slide, please. And this resulted in a crude hazard ratio of, not hazard ratio, odds ratio of 1.4. And we used 2 different models, expert models, decided by our Scientific Monitoring Advisory Council to adjust for certain risk factors. One was adjusted for age, BMI, breastfeeding at insertion, and parity. This increased the risk, Mirena versus copper IUD, slightly to 1.6. And basically exactly the same number we found in the second expert model, adjusted for age, BMI, time since last delivery, and experience of the inserting HCP. So this is basically the figure we found, an increase in risk of perforation of 1.6 compared to copper IUD, not statistically significant. Next slide, please. The majority of women who experienced the perforation in our study had some risk factors at insertion. So 29 of our women with the perforation were breastfeeding, some of them more than 6 times per day. We had 3 users who were given prostaglandins prior to insertion, and 19 that had some kind of anesthesia before perforation. Before insertion, sorry. 2 cases occurred during sounding, so there was no device inserted. The perforation was set already before. I think it was 1 case of copper IUD and 1 case of Mirena planned insertion occurred. The good thing and reassuring thing we found is that there was no generalized septic complications, such as peritonitis or septicemia, in any of these diagnosed perforations. And we also had no malfunction of bowel or bladder after a perforation. So all of the perforations we found were, from a clinical point of view, easy to handle. Next slide, please. Surprising for us was really the impact of breastfeeding on the risk of perforation. This is something we didn't expect in this magnitude. As you can see here, for both LNG and copper IUD, we had more than a 4-fold increase in risk in breastfeeding women compared to non-breastfeeding women. And since we were also interested in the impact of breastfeeding and time since last delivery separately, so if they are interacting or if they have their own risks, we did a stratified analysis on these 2 risk factors on the next slide. where we stratified time since last delivery, 36 weeks and below, and more than 36 weeks. And this is something I have to explain because 36 weeks seems very long. But this is really, these analyses were data driven. We saw in our plots basically that the risk in our study population at least really dropped only after 36 weeks. There was also a drop at 24 weeks, but we do not have very early insertions in Europe, or we didn't have them in the 2000s, in the early and mid 2000s. So there was basically no insertions before 6 weeks after delivery. This might explain perhaps this delayed drop in risk somehow, but we differentiated or stratified here time since last delivery and breastfeeding, yes and no. And as you can see, even in the substrata time since last delivery, 36 weeks and less, and more than 36 weeks, we see an independent risk of breastfeeding. In both cases, statistically significant, 2.3 and 4.3. And we also saw a risk independent of breastfeeding for time since last delivery. Also statistically significant, 2.5-fold increased risk, 36 weeks and less compared to above 36 weeks. So these two risk factors work independently. Next slide, please. Most of the cases of the perforation cases were diagnosed, or half of the cases were diagnosed due to pain and or bleeding problems of the woman. So this is actually what led these women to their HCPs and at the end of the day to the diagnosis of a perforation. But there was also a good proportion who was diagnosed during routine checks. So basically the woman didn't have any or very limited complaints. So it didn't drive her to go to the doctor, basically. So this was then chance findings, basically. We had also 2 cases that was only diagnosed at the planned removal. So the strings couldn't be found and the woman just didn't find the IUD when the removal was planned. Next slide, please. Most of the perforations had to be handled by laparoscopic or laparotomic removal, but we had also a couple of cases in which the IUD was removed vaginally. And the reason is that we also counted partial perforations in this study. So where the strings or part of the IUD was still in the endometrial cavity and only the other part, basically the other half, was in the abdominal cavity already. Next slide, please. So the conclusions, what we found in the study was increased risk of perforation for Mirena users compared to copper IUD users, which was not statistically significant. And since the odds ratio of 1.6 is not very, I'm missing the word, very strong, and in a word of epidemiology, this association of magnitude is too low to really discriminate among bias, confounding, causation, and chance as an alternative explanation. We stressed very much, yes, there could be an increased risk for Mirena versus copper IUD, but based on the data we found in this study, we cannot say for sure. What we can say is that only approximately 50% of the cases of the patients experienced a perforation actually had symptoms. Yeah, thank you. I'm handing over to Beatrice now, presenting infections as an adverse event of IUDs.
Great, thank you. Thank you for inviting me to speak. Good morning, everyone. Next slide. I do IUD research. Next slide. So I wanted to talk about historical concerns about IUDs and PID. We know that this is a pretty big topic, but we'll talk about historical concerns, risk of infection after IUD insertion, as well as eligibility for IUD insertion in specific patient populations. Next slide. There have been historical concerns about infections with IUDs, as Dr. Schwartz mentioned earlier, and this actually dates back to the 1920s, including serious or fatal pelvic infections associated with IUDs, such as a Grafenberg ring, pictured to the right here, before the antibiotic era. Next slide. Unfortunately, there are also multiple reports of serious pelvic infections with the Dalkon shield in the 1970s that raised further concerns about the safety of IUDs. Next slide. Upon further investigation, it actually appeared to be the multifilament tail of the Dalkon shield. You can see a picture of the scanning electron microscope photo of the multifilament's tail over in the middle there that appeared to be associated with infection. And you can see from the photo in the lower right that, that when you actually looked at photomicrographs of obliquely sectioned tail strings, that you can actually see bacteria between the filaments of the Dalkon shield's tail from this classic article by Tatum et al. So it appeared to be a multifilament tail that was associated with the Dalkon shield infections. Next slide. So what are the data around IUDs infections? What do we know now with modern IUDs? Let's start off by talking about the risk of infection with IUD insertion. Next slide. In a classic article looking at the bacteriologic studies of the endometrium after IUD placement, Dr. Michel and his colleagues enrolled patients undergoing hysterectomy who had Lippes loop IUDs placed anywhere from 4 hours to 7 hours before their hysterectomy. They performed transfundal endometrial sampling to avoid contamination of the samples from the endocervix. Although insertion of an IUD resulted in initial bacterial contamination of the endometrial cavity within the first 24 hours, the bacteria were actually quickly eliminated from the endometrial cavity within 48 hours in 80% of uteri. And by a month after IUD insertion, the endometrial cavities were actually sterile and pelvic infections were rare. The bacteria from the endometrium were generally consistent with the bacteria that grew from the endocervical cultures, which supports the theory that of mechanical transfer of bacteria from the endocervix into the uterine cavity during IUD insertion. Next slide. This was another classic study which used clinical trial data from 13 studies conducted by the World Health Organization to look at PID rates after IUD insertion. The study included almost 23,000 women who had one of 10 types of IUDs inserted, most commonly the copper T 220C. They included a modern type of IUD. They included women who had STI. They excluded women who had an STI in the past or sexually transmitted infection in the past 6 months or possible PID, but did not screen for STIs at insertion. The overall rate of PID was 1.6 per 1,000 woman years. But after adjusting for confounding, the researchers found that the PID risk was more than 6 times higher during the first 20 days after insertion than during later times, as demonstrated by the orange line compared to the light blue line, and occurred infrequently beyond the first 20 days. They concluded that PID among IUD users was related to the insertion process and to the background risk of sexually transmitted infections after the initial insertion process. Next slide. In contrast, in the Access IUS study, which is a multi-center phase 3 efficacy study of Liletta that enrolled over 1,700 women, almost all participants had chlamydia and usually also gonorrhea testing at screening, and almost 80% underwent IUD placement on the same day as screening, so screen in place. 29 participants had positive baseline STI tests, and none of those participants developed a pelvic infection. Only 9 participants developed PID over 2 years at an overall rate of 0.6%, with 3 cases within the first 7 days and 6 cases occurring after day 30. So in summary, they did not find an increased risk of PID in the first few weeks after LNG IUD placement in a low-risk population that was almost universally screened for STIs at time of placement and universally had antiseptic placed on their cervix to clean the cervix prior to IUD placement. Next slide. So why do we worry about PID? One reason is because of PID's association with infertility. And there have been a lot of concerns that IUDs cause infertility. However, many studies linking IUDs to PID or to infertility were flawed and fraught with bias, including selection bias, diagnostic bias, and confounding. Biases and confounding are more likely to affect case control studies and cohort studies, as you can see from this table, from an article that outlines the challenges of research about IUDs and PID. And so a randomized control trial would seem to be most useful to really look at whether or not there's a relation. Next slide. or sorry, not randomized study, a well-designed case control study would be helpful. And to answer the question about whether IUDs are associated with infertility, this was actually a very well-designed case control study that included null-gravid infertile women with and without documented tubal infertility and primogravid pregnant controls. They demonstrated that prior chlamydia exposure, as demonstrated by presence of antibodies to chlamydia and not prior IUD use, was associated with tubal infertility. Thus, in this well-designed case control study, use of a copper IUD was not a risk factor for tubal occlusion in null-gravid women. Next slide. Is there anything we can do to reduce risk of infection with IUD insertion? Should we give prophylactic antibiotics beforehand? Should we be screening for STIs first? Does it matter what type of IUD we insert? Are there certain populations who might be at increased risk for infection after IUD insertion? And hopefully I'll answer these questions in the following set of slides. Next slide. We've discussed that the risk of PID may be higher within the first 20 days after IUD insertion, although modern studies question that finding. Should we be giving prophylactic antibiotics before IUD insertion? And there have been several randomized trials conducted to look at antibiotic prophylaxis before IUD insertion. A meta-analysis of these trials found that although prophylaxis reduced frequency of unscheduled return visits by 18%, there was actually no statistically significant reduction in PID. Thus, prophylactic antibiotics are not recommended before IUD insertion. Next slide. Do you need to wait for gonorrhea and chlamydia test results before placing an IUD? We know that the overall rate of PID among people who undergo IUD insertion is low, ranging from 0 to 5% among people with STIs at time of insertion, and 0 to 2% among people without STIs. We know from a large retrospective cohort study of all IUD insertions at Kaiser Permanente, Northern California, over 4 years, that not screening for gonorrhea and chlamydia has equivalent risk of PID to any screening in the past year, and that same-day screening has equivalent risk of PID to pre-screening. And we know from a secondary analysis of the Contraceptive Choice Project, which was a prospective cohort study providing over 9,000 women with no-cost contraception of their choice, that risk-based screening, in other words, screening based on CDC guidelines, such as age less than 25, multiple partners, inconsistent condom use, or history of STIs, has high sensitivity for detection of gonorrhea and chlamydia. Next slide. And that's why the ACOG committee opinion on access to contraception actually recommends same-day LARC insertion visits, since 2-visit to IUD insertion protocols can be a barrier to contraceptive access, and that STI screening can occur on the same day as LARC placement. You do want to delay IUD insertion if someone has current PID or current purulent cervicitis or known gonorrhea chlamydia. Next slide. So does it matter what type of IUD we insert in terms of risk of PID, a copper IUD or a levonorgestrel releasing IUD? Since levonorgestrel releasing IUDs thicken cervical mucus, they're thought to potentially have a decreased risk of PID compared to copper IUDs. In a randomized multi-center study comparing the Nova-T copper IUD to the levonorgestrel releasing IUD did find a significantly decreased PID rate in users of the LNG IUD, which is a solid line, the lower line in this figure, as compared to the copper IUD, demonstrated by the dashed line. Next slide. However, another large randomized multicenter study comparing the LNG IUD to a copper T 380 AG IUD found no difference in PID rates between the two groups. Thus, data are mixed about whether or not LNG IUDs actually decrease the risk of PID. Thus, we should really ensure that we're counseling patients about other differences between IUDs, such as non-contraceptive benefits and side effects, to ensure that people are receiving the contraceptive option of their choice. Next slide. So are there certain populations who might be at increased risk for infection after IUD insertion? There are theoretical risks or concerns about infection for all of these groups, such as increased risk of infection or PID for people who might be at increased risk for infection. For people living with HIV, there have also been concerns about whether or not there's increase in female to male transmission of HIV through increased viral shedding or menstrual blood loss. There's a question of whether people at high risk for HIV may have an increased risk for HIV acquisition. For people who are immunosuppressed, a published case report in 1981 a case report was published of 2 pregnancies that occurred in patients with immunosuppression, and that raised the question of whether or not there's possibly decreased efficacy of copper IUDs. And although I know we already discussed that prophylactic antibiotics are not needed for IUD insertion, should they be provided for people at higher risk for infective endocarditis? Are people at higher risk for STIs at higher risk for PID as well? Next slide. What we know so far is overall is reassuring for people with HIV. A study of HIV-1 seropositive women who received IUDs in Kenya had cervical swabs collected before IUD insertion, as well as 4 months later to evaluate viral shedding, and found no statistically significant difference between baseline and follow-up in a multivariate model. A study looking at HIV-infected and non-infected women who received a copper IUD also found no difference in infection-related complications over 4 months, short-term, as well as 2 years, 2 years after insertion, after controlling from confounders, although the study was not adequately powered to look for differences in rates of PID. A systematic review in 2016 of safety of IUDs in women with HIV and AIDS was reassuring about lack of differences in infectious complications, and HIV transmission, viral shedding, and disease progression in IUD users. And thus, the CDC medical eligibility criteria for contraception considers copper and levodostrel IUDs to be MEC category 1, which means no restrictions, for clinically well people receiving antiretroviral therapy, and MEC categories 2 and 1 for people who are not clinically well or are not on antiretroviral therapies for initiation and for continuation and initiation respectively. Next slide. Or sorry, initiation and continuation respectively. In terms of whether people at high risk for HIV are more likely to acquire HIV when using an IUD, the ECHO trial provided reassuring data. The ECHO trial was a randomized, multi-center, open label trial that randomized almost 8,000 HIV-negative women seeking contraception to dihydroxyprogesterone acetate, a copper IUD or levodostrel implant for 18 months. The study was designed to address concerns about a possible increased risk of HIV acquisition in DMPA users that appear to be as high as 40 to 50% in meta-analyses of epidemiologic studies. In conclusion, the investigators did not find a substantial difference in HIV risk between the 3 methods when analyzed both as modified intent to treat, as well as in an analysis restricted to continuous use of the randomized method without any method switching. All methods were safe and effective with low pregnancy rates. And there were 2 systematic reviews conducted after the ECHO trial results were released that evaluated HIV acquisition with hormonal contraception and with copper IUDs. They found that there is no existing evidence on levodostrel IUDs, but existing evidence for copper IUDs do not show an increased risk of HIV acquisition. Next slide. Thus, after the ECHO trial and after a World Health Organization update to the WHO MEC, the CDC's MEC for women at high risk for HIV infection as of 2020 shows that both types of IUDs are now category 1 with no restrictions instead of category 2 for both initiation and continuation in people at high risk for HIV. Next slide. In regards to whether IUDs would be less effective in people who are immunosuppressed, such as transplant patients, the thought is that macrophages likely play a major role in contraceptive effect for IUD users, especially copper IUD users, and are minimally effective by most immunosuppressants, which typically work through mediating T-cell responses. Thus, there doesn't appear to be biologic evidence for decreased efficacy of IUDs in people with solid organ transplants. Case series and survey literature on people with transplants who are using IUDs for contraception are limited, but also overall reassuring in terms of efficacy and safety. When you extrapolate from the HIV literature, which are also reassuring in regards to safety of IUDs, IUDs are thought to be a safe and effective option for people with immunosuppression. Next slide. And this is supported by the CDC medical eligibility criteria for contraception, which considers IUDs to be MEC category 2 for people with uncomplicated solid organ transplants, as well as category 2 for people with lupus who are on immunosuppressive therapy. Next slide. For people with cardiac conditions that put them at increased risk for infective endocarditis, the updated guidelines on prevention of infective endocarditis from 2007 now says that, quote, the administration of prophylactic antibiotics solely to prevent endocarditis is not recommended for patients who undergo GU or GI tract procedures. This includes things like colonoscopies. This differs from prior AHA guidelines where prophylaxis was actually recommended for some GI or GU tract procedures. Since the thinking now is that infective endocarditis is more likely due to random bacteremias associated with daily activities and not with bacteremia caused by GI or GU tract procedures. And the risks of antibiotic-associated adverse events exceeded any potential benefit from prophylactic antibiotics. Thus, you do not need to give prophylactic antibiotics for infective endocarditis prevention. Next slide. What about users at high risk for STIs? Can they use an IUD? This was a secondary analysis of the CHOICE project that compared rate of PID in participants who tested positive for gonorrhea and or chlamydia at enrollment and for, compared to those who tested negative. This was a higher risk population where 40% of participants reported a history of STIs and 7.3% tested positive at the baseline enrollment visits. Overall, the rate of PID among IUD users was low, ranging from 0.44% among those who tested negative at enrollment to 1.1% among those who tested positive at enrollment. A systematic review of the safety of IUD initiation among people with asymptomatic cervical infections or increased risk of STIs suggested that IUD placement does not increase the risk of PID compared to no IUD placement. And in summary, IUDs can be offered even to people at high risk for STIs, and they should be encouraged to use condoms consistently. Next slide. So what do you do if PID is diagnosed after IUD insertion? A systematic review found that people who retained their IUDs had similar or better outcomes compared to those who had their IUDs removed. Thus, both CDC MEC guidelines and the CDC's STD treatment guidelines recommend that IUDs do not need to be removed if a person is diagnosed with PID. But if there's no clinical improvement within 48 to 72 hours after starting antibiotics, then clinicians should consider removing the IUD. Next slide. So how many of you have had patients come in reporting recurrent yeast infections or recurrent BV and requesting that their IUD be removed? I know I definitely have. Next slide. In terms of things like bacterial vaginosis, one question is there an increased risk for PID in people with BV? Are IUDs associated with increased risk of BV? Can you place IUDs with BV at time of insertion? And should you screen for BV at time of IUD insertion? A large longitudinal study of over 1,100 women in the US by Ness et al. Found that BV is not associated with development of PID after adjusting for confounders. Although this study was not specific for IUD users, it was just looking at BV in general. A prospective study by Achilles et al. That examined microbiota changes in people initiating and using various contraceptive methods found an increasing prevalence of asymptomatic BV over time in people initiating copper IUDs in Zimbabwe, ranging from 27% at baseline to 49% at 180 days. However, a sub-study of the CHOICE project demonstrated that the association between IUD use and BV appears to be mediated by irregular vaginal bleeding and not by just IUD use in general. There does not appear to be a role for screening for BV before IUD insertion, and the CDC MEC considers vaginitis to be MEC category 2 for both initiation and continuation of the IUD. Next slide. What about yeast? Although the studies listed on this slide all have various limitations, a case control study looking at vaginal colonization by Candida species in IUD and users and non-users found a higher rate of yeast in IUD users of 20% versus 6%, although the study was poorly described. Other studies suggest an increasing prevalence of Candida over time after LNG IUD insertion. In a prospective study by Donders et al., looking at the short and long-term effects of LNG IUD insertion on vaginal microflora, they found increase in Candida prevalence over 5 years after insertion. Lassard et al. Similarly found higher rates of candidiasis detected on Pap tests after 4 years of use of LNG IUDs. And a cross-sectional study looking at liquid-based cytology results found a higher incidence of Candida species with LNG IUD users compared to copper IUD users, particularly with longer-term use. And you might be wondering why this might be occurring. Next slide. One possibility is due to biofilms. Biofilms are structured communities of bacteria that are adherent to substrate, such as indwelling medical devices like an IUD or biological issues like the vagina. Biological tissues, not tissues like the vagina. They can be difficult to eradicate due to decreased susceptibility to antibiotics or antifungals, and they can potentially cause persistent and chronic or recurrent infections. Next slide. Both bacterial vaginosis and Candida biofilms have been described on removed IUDs, including from IUD tails. In one study by Zoran et al. That looked at Candida biofilms and removed IUDs, almost half of the Candida species were non-albicans, which are typically associated with resistance to antifungal treatments. A study by Trousseau et al. Found that all parts of an IUD can allow for in vitro adherence to yeast cells, including on the IUD tail. And this may contribute to why some patients experience recurrent vulvovaginal candidiasis and recurrent bacterial vaginosis, and why some patients report resolution of their recurrent BV or yeast infections after IUD removal. Next slide. So I'm sure many of you have also received Pap smear results that show that say that the cytology sees actinomyces. Actinomyces is an anaerobic gram-positive bacilli, which is an opportunistic pathogen and has been reported in case series to cause serious pelvic abscesses in IUD users. They look like woolly clumps on the cytology slides, as you can see in the image in the corner. Their average prevalence of actinomyces positive Pap smears is about 7%, although sensitivity, specificity, and positive predictive value were low. And only half of women with pelvic abscesses due to actinomyces were noted to actually have had a positive Pap test positive for actinomyces-like organisms. Given the low positive predictive value, the recommendation is that in an asymptomatic woman with an IUD and actinomyces-like organisms on the Pap, the IUD may be left in situ. Next slide. In conclusion, STIs, not IUDs, are associated with tubal infertility. Although the Farley study found that the highest risk of infection after IUD insertion is in the first 20 days after insertion, more recent studies demonstrate an overall low rate of PID with IUD insertions, including shortly after IUD insertion. Thus, many specific patient populations who are typically at higher risk for infection are still eligible for IUD use. Thus, same-day STI screening is safe and reduces barriers to care. Prophylactic antibiotics are not indicated before IUD insertion, even in those at high risk for infective endocarditis. And biofilms may play a role in recurrent BV and recurrent BV and vaginal candidiasis. And in summary, clinicians should provide patient-centered contraceptive counseling to ensure that patients are receiving a contraceptive method of their choice without barriers to care and without concerns about infections. Moving on to Dr. Allen to talk about pain next.
Great, thank you, Beatrice. Good morning. I'd like to thank the conference organizers for inviting me to speak. Next slide. I'm planning to review the use of the intrauterine device and pain, focusing mostly on pain with IUD insertion, but also pain with IUD use and the use of the levonorgestrel IUS to treat pain syndromes. Next slide. For most women, the pain experience with IUD insertion is mild to moderate and less than anticipated. However, some women are anxious about the possibility of pain or have risk factors for increased pain. Fear of pain can be a barrier to IUD access. So as clinicians, it's important that we recognize risk factors for increased IUD insertion pain so we can better counsel our patients and offer interventions as necessary. Studies have consistently shown that nulligravid and nulliparous women have increased IUD insertion pain, as well as individuals who have only had cesarean deliveries. Furthermore, anticipated pain and anxiety affect the amount of pain experienced, and a history of severe dysmenorrhea can be a red flag for increased pain with IUD insertion. Finally, the farther that one is out from pregnancy, the increased amount of pain may be experienced with the procedure. However, studies that have looked at insertion timing at different parts of the menstrual cycle have generally showed no effect on the pain experienced. We also don't want to forget, however, individuals who may have a history of sexual trauma or previous negative experiences with pelvic examinations that will also impact their experience with IUD insertion. Next slide, please. As we all know, tenaculum application to the cervix is a necessary step of IUD insertion in order to straighten out the angle between the cervix and the uterus to ensure that the uterine sound and IUD applicator can pass through the internal os of the cervix and reach the uterine fundus. I'm going to address the pain experienced with tenaculum placement with different types of tenaculums first. One randomized controlled trial compared the standard single-tooth tenaculum to an atraumatic tenaculum prior to IUD insertion in a trial out of New York City. No difference in pain was perceived, but they did find, not surprisingly, that the time to control pain, to control bleeding from the tenaculum site took longer with the single-tooth tenaculum compared to an atraumatic tenaculum. Another study from England had similar findings using another type of atraumatic tenaculum called a Littlewood forceps. Next slide, please. What about the techniques for tenaculum application? One study out of North Carolina looked at slow closure of the single tooth tenaculum over 5 seconds to the first ratchet, comparing that to asking the patient to cough with tenaculum application in order to distract them. And this study did not find any difference in the pain perceived by the patient. And the patients in this study had mixed parity. Next slide, please. In terms of pharmacologic interventions to decrease pain during tenaculum placement, we do know that injected lidocaine or anesthetics are effective in reducing pain with tenaculum placement. Some topical agents can work as well, as long as they are administered for long enough for the gel or cream to take effect. One study of 4 cc's of 2% lidocaine gel versus placebo gel that was self-administered by the woman 5 minutes prior to IUD insertion did not show any effect on IUD insertion pain, but did find a decreased pain with speculum placement and also tenaculum application. And this was a study among nulliparous women. However, another study that was similar, which actually applied a greater amount of 2% lidocaine gel, 20 cc's, for longer, 15 minutes before the procedure, similarly found a decrease in pain with speculum insertion, but did not find the same decrease in pain with tenaculum application among 215 subjects. So the data are conflicting on 2% lidocaine gel for tenaculum placement. And the differences in the two studies may have to do with the technique for tenaculum application or just whether or not the self-administered gel actually reached the cervix. Next slide. Moving on to pain with the actual IUD insertion, which after tenaculum placement includes sounding the uterus and placing the IUD. Studies show that as providers, we often underestimate the amount of pain that our patients are experiencing during IUD insertion. So we need to do a better job making patients feel comfortable. It is important to remember that there are several non-pharmacologic approaches that can be useful in helping patients relax for the procedure, although there's not much evidence for a real effect on the pain experienced. Aromatherapy with lavender has been shown to decrease anxiety surrounding IUD insertion. Next slide. For pain with the actual IUD insertion, these agents have been shown to be ineffective. In a more recent study from Sweden, a larger volume of intrauterine instillation, 10 milliliters of mepivacaine, was found to be slightly effective among nulliparous women, but the decrease in pain was not clinically significant, being only 1.1 centimeters difference on a 0 to 10 centimeter visual analog scale. Therefore, more studies of intrauterine infusions need to be performed. Next slide. The most promising and commonly used intervention for decreasing pain with IUD insertion is the paracervical block. This randomized controlled trial by Dr. Modi demonstrated that although the block itself was painful compared to a sham block, there were significant reductions in pain with uterine sounding and IUD insertion, and also 5 minutes post-insertion. This study utilized both Mirena and Paragard IUDs among nulliparous women. This finding was confirmed in another study using a smaller paracervical block with 10 cc's of 1% lidocaine among nulliparous women having Skyla insertions. A more recent randomized controlled trial from Brazil also showed that 3.6 milliliters of 2% lidocaine and a 4-point intracervical injection administered with a 27 gauge needle was also effective for tenaculum placement pain and IUD insertion pain among nulligravid women undergoing Mirena insertion. Next slide. Other local anesthetic agents that have been proven effective, although not as widely used, are 10% lidocaine spray and amla cream. And there is also a novel viscous 4% lidocaine gel that's being developed for use that adheres to the vagina better and stays in place compared to the 2% lidocaine gel product that is commonly available. Next slide. I'm going to discuss oral and intramuscular agents now. These agents have mixed efficacy for the IUD insertion itself. Studies have shown that ibuprofen is ineffective for IUD insertion pain. Next slide. When looking at ketorolac, the oral version was found to be modestly effective for both insertion pain and post-procedure pain in a Canadian study when given 40 to 60 minutes prior to the procedure, as you can see there. The intramuscular version also showed a decrease in pain, about 1.6 centimeters on the 10 centimeter visual analog scale, but it wasn't statistically significant in the total population. It did have more of an effect in the subgroup of nulliparous women in this study, a 2.7 centimeter difference. However, there were only 16 nulliparous patients and the sample size was too small to draw definitive conclusions. Similar to oral ketorolac, intramuscular ketorolac worked well for post-insertion pain. Next slide. Naproxen is another NSAID that has been studied for IUD insertion pain. In one randomized controlled trial from California, 550 milligrams of naproxen 1 hour before had no effect on IUD insertion pain among nulliparous women. However, it did help reduce pain post-procedure. In contrast, one trial from Turkey showed that naproxen was equivalent to tramadol in terms of decreasing IUD insertion pain among multiparous women. The differences between these two studies might have to do with different study populations. Next slide. Misoprostol is a prostaglandin analog that has been studied for both easing the IUD insertion procedure and decreasing pain with IUD insertions. Most studies do show that it eases IUD insertion from the perspective of the provider. However, there's no evidence that it actually reduces the risk of failed insertions, even among nulliparous patients. Effects on pain are mixed, but most experts feel that the abdominal cramping caused by misoprostol outweighs any benefit on pain during the IUD insertion itself. It has been shown to be helpful in one study of women who had a previous failed IUD insertion in terms of increasing the odds of success for the subsequent attempt. Next slide, please. To conclude, there are many randomized trials evaluating different interventions for pain with IUD insertion. Certain treatments have emerged as being effective and are more commonly available, such as local anesthesia in the form of a paracervical block. Given that women with vaginal deliveries typically tolerate IUD insertion well, it makes sense to individualize care based on patient factors and offer interventions to those individuals likely to benefit, such as nulliparous patients or patients with higher level of anxiety surrounding the procedure. All NSAIDs have been shown to work for post-procedure cramping, so this is a useful intervention, but routine misoprostol use is not advised. A study of adolescent and young adult women showed that satisfaction with the IUD insertion procedure was inversely related to a high pain score, not surprisingly. So it does behoove us to make sure the patient is as comfortable as possible. Next slide. I'm going to move on and talk about the pain experiences of patients in the days following IUD insertion. This was an interesting study that followed both nulliparous adolescents and paris adults for 2 weeks after levonorgestrel IUS insertion. These patients recorded daily pain scores for 2 weeks on a 0 to 10 scale. The time of day was not noted by the study, but I assume that it was supposed to be a recording of the worst pain experienced during that day. Adolescents were prescribed ibuprofen to take as needed for cramping. Adults relied on over-the-counter medications, but recorded all the medications that they took. Next slide. The study enrolled 46 adolescents and 47 adults. The average pain score over the first 3 days post-insertion was 3.85 in the adolescent group and 2.56 in the adult group. You can see from this graph that adolescents experienced more pain post-insertion than adults. but both groups had a decline in pain over the 2 weeks. It was found that previous delivery type, vaginal versus cesarean, did not affect pain scores in the adults, and whether or not the adolescent had had sexual intercourse previously also did not affect their pain scores post-insertion. Next slide. This graph shows ibuprofen use on each day post-insertion. One can see that on day 1, between 60 and 70% of both groups used ibuprofen, and that the rate dropped off quicker for adults compared to adolescents. I think this study is useful because it reveals the experience of patients after they leave our clinics. Clearly, we should be counseling patients to expect some cramping after IUD insertion and need for ibuprofen, with a small minority of patients requiring ibuprofen up to 2 weeks post-insertion. Next slide. For some women, copper IUDs can cause increased menstrual blood loss and pain. Dysmenorrhea is one of the most common causes of IUD discontinuation among copper IUD users. NSAIDs can reduce menstrual blood loss and pain as they counteract excessive prostaglandin release in the endometrial cavity. This study was conducted to determine if prophylactic use of ibuprofen taken during menses could prevent discontinuation of the copper IUD. Unfortunately, the study had negative findings among this group of majority Paris patients who were followed for 1 year. It is unknown if higher doses of ibuprofen could be helpful or if the results would have been different if a largely nulliparous population was studied. Next slide. A Cochrane review did show, however, that NSAIDs are effective in reducing pain with IUD use. And so we can certainly advise our patients to take NSAIDs if they are experiencing cramping. And there's no evidence that one NSAID is superior to another. Next slide. Certainly, complaints of pain with IUD use should prompt evaluation for IUD location, as this may be a sign of partial or complete expulsion, or more rarely, a perforation. Assuming the IUD is properly located, one can consider alternative causes of pain, but also honor patients' requests for IUD removal if they so desire. Next slide. Finally, I'd like to touch on the use of the levonorgestrel IUS for pain syndromes. This was a randomized controlled trial that compared the etonogestrel implant to the levonorgestrel IUS for endometriosis-related pain. Participants were randomized to the treatment and then recorded daily pain scores for 6 months. Both methods worked extremely well in reducing both non-cyclic pelvic pain and dysmenorrhea, which was defined as pain during bleeding episodes. But there was no difference between the two methods. Therefore, the levonorgestrel IUS can be offered as a treatment option to patients who are interested in this method of treatment. And it does have the advantage of not containing estrogen and doesn't have the same effects on bone that GnRH agonists would have, and can be used long-term for the treatment of endometriosis. Next slide. For patients undergoing surgery for endometriosis, it is recommended that they often go on a suppressive therapy post-operatively for at least 6 months, sometimes up to a year or more, to prevent recurrence of endometriosis. Patients can opt for several treatments post-operatively, including continuous combined oral contraceptive pills or GnRH agonists. But the levonorgestrel IUS has also been shown to be an effective option in systematic reviews in reducing both dysmenorrhea and non-cyclic pelvic pain, and it has been shown to be equivalent to GnRH agonist treatment. The mechanism of action of the levonorgestrel IUS in treating endometriosis pain is not completely elucidated, as it doesn't have the effect of some other methods of reliably inhibiting ovulation, as we've heard previously. However, it does decrease menstrual blood loss, and it is thought that local or systemic levels of levonorgestrel can cause atrophy of endometriotic lesions. So this is an effective option that we can offer our patients. Okay, that's my final slide. And I'm going to move on to Dr. Baldwin, who is going to address IUDs and bleeding.
Thank you. Hi, everyone. I'm going to cover bleeding outcomes with IUDs. This topic is important to me in my clinical work, managing heavy menstrual bleeding and bleeding disorder. Next slide. I will cover how bleeding outcomes are measured, length of initial bleeding changes, and whether that varies based on menstrual timing of placement or post-pregnancy placement. I'm not going to have time to discuss interventions for breakthrough bleeding though, and I'm going to work backward from special situations to the larger primary studies, relatively cherry picking from the many important studies on this topic. Next slide. Most studies have used a calendar method of a paper or electronic or text bleeding diary, categorizing bleeding into none, spotting, light, or heavy, with spotting usually defined as not needing hygiene products. The most accurate measurements of bleeding amount use the alkaline hematine method for measured menstrual blood loss. And the picture on the right shows the container used to collect all the menstrual blood for a cycle on specific menstrual products, which is then calculated into a volume amount. Heavy bleeding is considered more than 80 milliliters. And on the left, the PBAC requires participants to tally up their menstrual products and clots. Heavy bleeding is considered more than 100 points. While measured losses are the most accurate, both PBAC and patient report have good correlation. Next slide. There are key background articles that outline the research definitions for bleeding terminology known widely as the WHO Belsey criteria. Based on this, most studies report total days of bleeding or spotting, or both, per 90-day reference intervals. Definitions and terminology for unscheduled versus cyclic bleeding are also standardized. For example, infrequent bleeding is defined as less than 2 episodes of bleeding per trimester. Next slide. A lot of data is generated from bleeding diaries, and analysis requires some seriously higher level statistical skills. You can look at this array of bleeding patterns and see that there are possibly a few patterns emerging. Most data from large studies focuses on the mean number of bleeding and spotting days, or the proportion of participants with bleeding or spotting per day or per reference period. Next slide. This is the proportion of 137 participants experiencing bleeding on any subsequent day after their choice of copper or levonorgestrel IUS placement. Overall, it's apparent that in the lighter blue, more IUS users are bleeding on any day after placement up to about 90 days. But this level of data doesn't tell us if it's the same users having consecutive bleeding or not. And for example, in this study, 10% had no bleeding at all. Next slide. In this same study, investigators compared menstrual timing of placement by IUD type and found no difference in the initial mean number of bleeding days after placement, with on the bottom line there approximately 37 days versus 40 days in IUS users undergoing placement in the first week of the cycle versus later. There is also not an impact on later bleeding. The TIME trial from the Netherlands in 2016 assessing pain with timing of IUS insertion found that parity was associated with slightly more bleeding and spotting at 3 months, but that menstrual placement timing didn't matter. Next slide. And what about postpartum placement? For interval postpartum placement, when lochia might not be completed, placement is associated with a short increase in bleeding regardless of timing. The top left figure is placement randomized to prior to 6 weeks, and the bottom left is after 6 weeks. The copper IUD cohort on the right includes both randomization groups. Dark orange is bleeding, light orange is spotting, and green is no bleeding. And you can see a short-term increase in bleeding and spotting depending on timing of placement, which is in the shaded bars. Amenorrhea between 3 to 6 months didn't vary based on placement timing and was 32% overall for IUS and 23% for copper IUD, and most patients were lactating in this study. Next slide. And what about the impact of immediate post-abortion placement? This is a study from China comparing bleeding outcomes by IUD type placed after first trimester abortion. Using paper diaries, most reported normal baseline menstrual flow prior to the pregnancy. And first menses was light for most IUS users in purple on the left, which continued on to 6 months. First menses was heavy in about 5% of copper IUD users in that middle bar on the right, which improved by 6 months except for about 10% who had heavier than baseline at that time. And the average abortion-related bleeding days were 8 after IUS placement versus 7 after copper IUD placement in this study. Next slide. Before we look at bigger trial data, let's review US patient perception of bleeding outcomes. This is a secondary analysis of the Choice Project data of all comers seeking contraception. Participants underwent phone surveys, asked about perceived bleeding amount and frequency at 3 months compared to baseline, and then at 6 months compared to 3 months. There were 2,400 IUS users and about 700 copper IUD users by 6 months. As expected, about 2/3 of IUS users report less bleeding at each subsequent 3 months. And initially, 70% of copper IUD users reported more bleeding than baseline. And by 6 months, 19% had perceived even more, and 25% had noted improvement. Notably, these perceptions were not significantly associated with dissatisfaction, suggesting that counseling and method choice actually works. Next slide. And this is the same population when asked about perceived bleeding frequency. Most of these US patients using copper IUD reported regular cycles. Next slide. This is one of my most favorite slides for teaching, demonstrating the dramatic decreased total measured blood loss at 3 and 6 months after IUS placement in heavy bleeders. After baseline qualifying cycles, Paris heavy bleeders had mean reduction of menstrual losses by 83% at 3 months to 95% reduction by 6 months, compared to mean decline of only 13% with oral medroxyprogesterone acetate. And the few patients with continued heavy bleeding, several of them had expulsions. Several similar trends are also observed in nulliparous patients with heavy bleeding and in the bleeding disorder community as well. Next slide. What is the average number of days of bleeding to expect per month? This very large study randomized Paris patients to LNG 20 versus Nova T 200, including post-abortion placement. And the open circles are the copper IUD with bleeding and spotting on the left and bleeding only days on the right per month. Looking at the number of bleeding and spotting days by month here, it seems that steady state is reached as soon as about month 3 for copper IUD, but maybe not until month 8 or 9 for IUS, with a total of about 8 total days per month in copper IUD versus 4 days of bleeding and spotting per month for most using IUS, but really only about a steady state of 2 bleeding days for IUS users. Next slide, please. The 3 doses of LNG IUS have very similar trends. The column bars total to bleeding only plus spotting only by 90-day reference period over 3 years. These are also amenorrhea rates from the second 90-day reference interval to the last interval. And overall, while they vary by dose, the total achieved amenorrhea rates are fairly similar between the middle dose and LNG 20 of approximately 20 to 25%. Next slide. And what about bleeding patterns? This is data from the phase 3 trial of the newer 52 milligram IUS and includes a more detailed picture of bleeding patterns over 2 years in about 1,700 participants, including infrequent bleeding in red, which is 1 to 2 days of bleeding or spotting episodes, 1 to 2 bleeding or spotting total episodes in 90 days. Amenorrhea in dark blue, prolonged bleeding in purple, irregular bleeding in light blue, and frequent bleeding in green. Frequent bleeding is more than 5 episodes per 90-day interval. This trial includes nulliparous patients, including teens, and neither obesity nor parity consistently affected patterns in this study. Next slide. Well, are there predictors of more favorable bleeding patterns? There are some conflicting results about the impact of parity. In this pilot study of nulligravid patients, bleeding during the first 90 days didn't differ between IUS versus copper IUD. In the second 90 days, 41% of IUS users had scant or no bleeding. And one predictor of this pattern of amenorrhea or nearly amenorrhea was a smaller overall uterine cavity area, mainly due to fundal width. Uterine cavity length didn't have an impact. However, in multivariate analysis, only lighter baseline menses and smoking history were significantly associated with this pattern, and uterine area was no longer significant in these nulligravids. Next slide. It's worth noting that PBAC scores for copper IUD are really fairly high, averaging about 150 points by month 5. Older studies documented measured blood loss in a variety of copper IUD types, as well as ferritin declines in users, with other frames having even worse impacts on menstrual losses than the middle one here listed, which is the copper T200. And this demonstrates to me that those with heavy menstrual bleeding who prefer a non-hormonal IUD really should be counseled about menstrual losses and monitored carefully for iron deficiency. Next slide. Not only is there continued improvement with total number of bleeding and spotting days over the IUS use, there is also continued improvement in episode length progressively. Next slide. And this even appears to continue into the second IUS in obviously satisfied users, with continued increased rates of amenorrhea and minimal impact of the replacement on bleeding, up to a proportion of approximately 44% amenorrhea, or really up to almost 72% of nearly no bleeding at the end of the second IUS. Next slide, please. Finally, IUS is considered equivalent to ablation by 1 year for amenorrhea, hypomenorrhea, and satisfaction outcomes. So it is a really successful alternative to more invasive therapies for heavy bleeding. Next slide. And in conclusion, steady state bleeding is reached in 3 to 6 months for most patients, with initial bleeding episodes averaging about 40 days for both IUD types. There is continued improvement over the entire IUS length of use, including into the next one. The average patient has heavy menses and iron deficiency with copper IUD, but most appropriately counseled US patients are satisfied with that, and most have improvement for, over the second 90-day reference interval of use. Bleeding doesn't vary significantly by timing of placement, either initially or up to the second 3 months, by parity or by recent pregnancy. Less than 1 in 4 of those using the LNG 20 will have amenorrhea at 1 year. US patients report similar experiences to those collected with daily bleeding diaries in stringent research studies, which is reassuring. And now I will pass it off to Luis Bahamondes for a discussion of expulsion and reasons for discontinuation. Thank you.
Good evening, good afternoon, I don't know, good morning. Thank you very much for the organizing committee for the invitation. Next slide. The common reason for discontinuation of the copper IUD and levonorgestrel IUS are pregnancy, obviously, which is the worst reason for discontinuation, bleeding, and or lower abdominal pain that many publications put together. Expulsion, weight increase, PID, and perforation. And reasons only for levonorgestrel IUS users are acne and breast tenderness. Anticipated guidance about side effects might be a key approach to help women initiated an IUD. Next slide. What about pregnancy? Obviously, any pregnancy with IUD in situ must be interpreted as unplanned pregnancy. This is the WHO study published in 2016 with follow-up up to 6.5 years. And the pregnancy rate among copper T380 IUD was 2.1 cumulate, and the pregnancy for the levonorgestrel IUS was 0.2 cumulate up to 6 years. It includes all sites, including the China site of the study. The next one. However, in the year 2020, recently, Caroline Weston published a paper about the follow-up up to 5 years with the levonorgestrel IUS releasing 20 microgram day. And the cumulative pregnancy rate was 0.19 or 0.2, 2 women by 1,000 women, which is extremely low. Consequently, the probability as the continuation rate of pregnancies is very low. Nevertheless, the probability that pregnancy was ectopic are very high, almost 50%. Next slide. Regarding bleeding and pain, also with the WHO study, you can see that in the year 2016, many women discontinued due to amenorrhea, because at that time, and the center participating in the study, many women consider amenorrhea as a reason for discontinuation or a side effect induced basically by the levonorgestrel IUS. Reduced bleeding, the number of discontinuation are very low, but lower for the copper IUD than the levonorgestrel IUS, and the increased bleeding obviously higher for the copper IUD than the levonorgestrel IUS. It is important to recall that many years ago, women from low and middle income countries considered that amenorrhea is a side effect that doesn't like. It's different than today that many women like amenorrhea as a side effect induced by the levonorgestrel IUS, and as a reason for removal is lower than before. Next slide. The continuation rate due to lower abdominal pain, this is the European study. You can see that at the accumulated 60 months for the Nova T, copper Nova T was 2.7, and for the levonorgestrel IUS 2.0. Practically equal for copper IUD than the levonorgestrel IUS, and very low for lower abdominal pain. Next slide. And also in a study from Phillips in the American Journal of Obstetrics and Gynecology in the year 2017, you can see that the abdominal pain rate by 5 years with the levonorgestrel IUS accumulate was 11 and 8% for the copper T308, but the bleeding problem 5% only for the levonorgestrel IUS and 18% for the copper T308. It is important to recall that the main reason for discontinuation for the copper IUD cumulate for up to 10 years is lower abdominal pain and bleeding problems together. The next slide. Expulsion. Expulsion is complicated, and there are many systematic review and papers published about expulsion, because it is important side effect or reason for discontinuation, because many women, when expulsion is inadvertent, could become pregnant because they have not IUD in situ. But the predictors of the expulsion is placement in adolescent, within the first 6 months after placement, history of abnormal uterine bleeding. This is a recent paper published this year in the Journal of Pediatric Adolescent Gynecology. Expulsion was more likely if the levonorgestrel IUS placement occurred during the menstrual cycle days 1 to 8. This is also a new paper for the year 2020. And we published 20 years ago that levonorgestrel placement at the time of the days of acute heavy menstrual bleeding, the expulsion rate is 3 times higher than the insertion outside the bleeding period. Next slide, please. But no risk factor associated to expulsion. Nulliparity, and many providers believe that nulliparous women or nulligrade women present more expulsion rate is not true. And the category of professionals who perform the insertion also is not true if the professionals are well trained. We just published this year insertion performed by faculty member, fellowship, resident in training, interns in training, and nurse, trained nurse, and the expulsion rate was exactly the same. Next slide. Other concern of women and reason for discontinuation of copper IUD and levonorgestrel IUS, mainly for levonorgestrel IUS, because many women believe that they use any hormonal contraceptive method provoke a weight increase, is this slide that we published in the year 2015, which showed that the levonorgestrel IUS and the copper IUD user up to 10 years, both groups increase the weight. Consequently, the weight increases consequently of the year that we pass, and not exactly to use of copper IUD or levonorgestrel IUS, but it is still a reason for discontinuation. Next slide. The PID, Beatrice Chen explained very well, but it is important to recall the old study from Tim Farley, from WHO at that time, which showed that the PID, the incidence of PID, which IUD use, is very, very low, 0.4, 0.5 from other studies, 0.5 from other. It's almost, Christina Gensel-Danielson in 2015 reported 0.4. Consequently, the reason for discontinuation of PID is extremely low, and as Beatrice showed, it is more related to previous infection and not to IUD use and the sexual behavior of the user. Next slide. And this is community rate and PID as reason for removal of up to 5 years for the levonorgestrel IUS in Finland and United States. You can see 1.4 from Bachman from Finland and 0.5 from Irving Simmons from United States. The next one. And this is an important study published this year regarding the return of fertility after removal of the levonorgestrel IUS 52 milligram, the Liletta from United States. And it is important to show that the cumulative pregnancy rate up to 12 months after removal is 86%. Obviously, there are no infertility after use of levonorgestrel IUS. Consequently, there are no effect on PID for users of levonorgestrel IUS. Next slide. Uterine perforation, I only have one slide because class explained very well. Breastfeeding is a risk factor for levonorgestrel IUS and copper IUD user, both groups. Next slide. And the reason for discontinuation, this is from the levonorgestrel IUS, the study in United States, accumulate for 6 or more years, and you can observe that total, the bleeding complaints, 2.3, acne, 1.4, dysmenorrhea, 1.0, weight increase, 1, mood swing, 0.8, uterine pain or pain, 0.7, pelvic discomfort or pain, 0.6, and dyspareunia, 0.6. Consequently, the reason for discontinuation for side effects among users of the levonorgestrel IUS for 6 or more years is extremely low. Next slide. But it is interesting to show, I would like to show 2 slides, because we are talking about the reason for discontinuation of IUS and IUD, but this is a study published this year from Amico from United States. This is barrier for discontinuation. Barriers posed by provider to remove IUD. And the objectives of that study was to assess barrier to IUD removal appointment. They conducted a study with mystery caller, 229 clinics. located in 10 mite and sided cities. The next slide. And the main result are that 62 could offer an IUD removal appointment. 61 provide an initial appointment within 2 weeks, median of 10 days. But the clinic offering IUD removal, 17% require more than 1 visit before removing the IUD. I cannot understand why the women need 2 appointments to remove an IUD. 5% reported that they will not remove an IUD that was not placed at their clinic, and the median cost of removal was $262, with a range from $60 to over $1,000 for removal. Next slide. In conclusion, most frequent reason for discontinuation, both for copper IUD and the levonorgestrel IUS, is bleeding and or lower abdominal pain. Expulsion is more common among adolescents than adults. Not frequent reason for discontinuation, both for copper IUD and levonorgestrel IUS, is pregnancy, PID, which first month after placement is high risk factor, uterine perforation, breastfeeding is risk factor, weight increase is unlikely, acne and breast tenderness only for levonorgestrel IUS is unlikely. Anticipatory guidance about side effects might be a key approach to help women initiating an IUD and to avoid early removal, which in many cases put the women in use on low or lower contraceptive effectiveness than IUD. Thank you very much for your attention.
Okay, it is 1 minute before the time we must end. I need to give enormous thanks to the speakers. As you all heard, there is a phenomenal amount of high quality data published in the literature to address all these issues. And it's a lot to all take in a short session. As you see on the screen, the event was recorded, so you can look it over. There will be the evaluation, but I think the real take home here is we have really excellent studies. There is a lot of high quality information we can use for giving our patients information. One thing I noted on the chat was a lot of interest in self-removal. And I want to remind everybody that in the session, the brief session that we first held back in May, we discussed self-removal extensively. And so I do refer you back to that session. Again, I want to thank the speakers very much and thank the sponsors for allowing us to make this happen. Thanks to Rachel for keeping us going. And I look forward to seeing people on January 27th for the next session where the main theme will be access to IUDs. Thank you.